Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from ASI.
Hello, I'm Dr. Lawrence Honig. I'm a professor of neurology at Columbia University Irving Medical Center in New York City. I'd like to welcome you all to this program, which is entitled Navigating the Future, a Clinical Roadmap for Anti-Amyloid Therapies in Alzheimer's Disease. Joining me today are Jane Reams, a nurse and caregiver for someone living with Alzheimer's disease, Dr. Anna Chodos, who is a professor of clinical medicine at the University of California, San Francisco, and Dr. Cyrus Raji, who is an associate professor of radiology and neurology and director of neuromagnetic resonance imaging, associate director of the Radiology Research Track Residency, and associate leader of the Knight ADRC Imaging Corps at Washington University School of Medicine and at the Mallinckrodt Institute of Radiology in St. Louis. Welcome all. During this program, we'll discuss the anti-amyloid treatment landscape. We'll discuss collaboration and shared decision-making across the patient, family, and specialty providers. And this panel will include perspectives from a caregiver, a neurologist, a geriatrician, and a radiologist. So let's take a look at the treatment landscape for anti-amyloid therapies. Firstly, we should address what are some of the goals of treatment in early-stage Alzheimer's disease. Those treatment goals include preservation of independence for as long as possible, an impact on progression, namely a reduction in progression or slowing of progression over time. They include maximizing the time that patients and their families have for planning, reducing care burden, and balancing, of course, benefits and safeties of any therapies. And finally, of course, the overall impact on quality of life is paramount. So what do the data tell us about these therapies? There are two anti-amyloid monoclonal antibodies approved by the Food and Drug Administration of the U.S. for Alzheimer's disease. Those are lecanemab and donanemab. These are disease-modifying therapies. They're indicated only for biomarker-confirmed early Alzheimer's disease, which might be mild cognitive impairment due to Alzheimer's disease or mild dementia due to Alzheimer's disease. They're both administered by intravenous infusion. Lecanemab infusions are about 1 hour, delivered every 2 weeks. The donanemab infusions are about 30 minutes, delivered every 4 weeks. So let's go over some of the data for lecanemab. Compared with placebo, there was a marked reduction in amyloid levels in the brains of people treated with lecanemab. Regardless of whether one looks at cognition/function or function as in activities of daily living, there is a slowing of progression when people are treated with lecanemab as compared to placebo. So there's less decline in cognition, there's less decline in functional impairment when you are on drug as opposed to placebo. In addition, there's open label data that suggests even after 18 months, there's a continued benefit of lecanemab. Everyone at 18 months who was in the study was given lecanemab, regardless of whether they had been on placebo or lecanemab in the first 18 months. There is a benefit of lecanemab, early treatment over lecanemab starting at 18 months. Both of these seem to do better than matched control participants from the ADNI study used as a comparator. Overall, people on lecanemab do better than people on placebo, and this seems to proceed beyond 18 months into the 36-month window, even though, of course, we do not have people who were treated with placebo for 36 months. On a variety of bases, there is now a recommendation that's in the package insert and approved by the FDA that after 18 months, one can consider maintenance dosing every 4 weeks rather than every 2 weeks. Well, that's my introduction to lecanemab. Donanemab looks rather similar in many ways, but not all. For example, with donanemab, just like with lecanemab, there is a marked reduction in amyloid burden on PET scanning. Approximately 80% of individuals treated with the drug were amyloid negative by 18 months. Like the prior drug that we talked about, there is a slowing of progression over 18 months when you're on donanemab versus on placebo. Both drugs had infusion reactions. By infusion reaction, we mean some reaction or adverse event that is perceived to relate temporally to the infusion, typically within 24 hours of infusion. 26.4% of persons in Clarity AD in the lecanemab trial had infusion-related reactions, a lower proportion, 8.7%, with donanemab. In neither drug was there a very significant percentage that had serious infusion-related reactions. Now, I think we should talk a little bit more about ARIA, which is the major side effect of these drugs. Not the major, maybe numerically, but the major side effect in terms of potential seriousness. Cyrus, would you like to talk a little bit more about that?
ARIA stands for amyloid-related imaging abnormalities, and our responsibility is to monitor and manage ARIA appropriately to prevent serious outcomes. When ARIA occurs, it tends to occur early in treatment and is typically transient and manageable in a clinical trial setting. The vast majority, upwards of 75% of ARIA cases, are asymptomatic, and when symptoms are present, they typically include headache, dizziness, unsteadiness, confusion, and visual disturbance. Magnetic resonance imaging, or MRI, is the most clinically useful tool for detecting ARIA. And in terms of the clinical trial results, when looking at lecanemab results, any sort of ARIA occurred in 21.5% of study participants versus 9.5% with placebo. And with donanemab, the rate was a bit higher at 36.8% versus 14.9% with placebo. In terms of serious ARIA with more adverse clinical outcomes, in both types of drugs, they were lower in percentage at 0.8% with lecanemab and 1.5% with donanemab. ARIA frequency was analyzed across donanemab clinical trials, and the key insights that were obtained from these trials were a better understanding of the risk factors for ARIA, particularly ApoE4 allele genotype, which is a risk allele for Alzheimer's disease, a number of microhemorrhages at baseline, and the presence of superficial siderosis at baseline as well. In terms of managing this risk, use of corticosteroids were most commonly employed when managing serious or symptomatic ARIA. It's important to note in looking at donanemab that the use of antithrombotics did not increase ARIA risk or frequency of symptomatic ARIA, and there was no evidence of interactions between antithrombotics and ApoE4 genotype observed.
The question then comes up as to who is eligible for treatment with an anti-amyloid therapy, and how do we determine that? As I mentioned earlier, the indications for treatment with these agents are either MCI due to AD or mild dementia due to AD. There's a requirement that amyloid pathology be confirmed. There's, of course, a need to tolerate multiple MRIs, as you heard from Dr. Raji, that multiple MRIs are required during the treatment phase to monitor for ARIA. Also, no clear exclusions for performing an MRI. Various experts and clinicians, of course, have come up with their own thoughts about what clinical factors might impel them to be less inclined or more inclined to offer these disease-modifying therapies. ApoE4 testing, it's not mandatory by the package labels, but encouraged. One question is anticoagulants or antithrombotics, as some people call them. And as you heard from Dr. Raji, the evidence there is not so clear that anticoagulation is necessarily a risk for side effects. There's a question of MMSE or MoCA cutoffs. Again, one makes the determination of MCI or mild dementia not on the basis of MMSE or MoCA, but on the basis of the clinical examination and various scales, and not typically one particular scale, but some individual practitioners choose to make a cutoff. There's the question of what concomitant psychiatric or immunological diseases might might make a person a less favorable candidate. And then finally, to return again to the MRI issues, there's the question of how many microbleeds present on a baseline scan pre-treatment make it less favorable to consider treating a person with these antibodies. And there's still other considerations such as body weight, ability to cooperate, age range outside of the clinical trials, still other factors. Let's talk a little bit about the actual exclusion criteria for the lecanemab and donanemab phase 3 trials. The issue here is that for both drugs, we have substantial numbers of people, most notably people with more than 4 microhemorrhages, who were excluded from the trials. So we don't really know how they would have fared with drug or placebo had they been eligible for treatment. And thus, we don't know exactly how to address these individuals in clinical practice. What I'd like to do now is open it up to Dr. Chodos and Dr. Raji and to Jane Reams to reflect on what they view as some of the key things to think about, both in terms of patient eligibility and ongoing treatment. Dr. Chodos, would you like to go first?
Sure, absolutely. As the generalist and geriatrician, I really appreciate the opportunity to be part of the conversation. For our patients, I think some of the initial considerations are really who's even at the point of being considered. In general practice, it isn't common to screen or focus on an early detection approach with Alzheimer's disease. That landscape may be changing, but I think really it's people who are advocating for themselves and bringing their symptoms to the attention of their providers who are getting through the workup and getting diagnosed with Alzheimer's disease at the earliest possible stages. So I think about that a lot, who's really getting access to the early diagnosis. The other thing is, as we have a very diverse country with folks with very diverse backgrounds, how are we doing the assessments? You mentioned the MMSE MoCA cutoff. And for many of the folks that I see, those tests wouldn't really be appropriate given their education level. And so I really agree with you on the point about really focusing on a clinical assessment of their symptoms and should they be going into a clinical care pathway where they get more assessment for actual Alzheimer's disease. I also think about how big a deal a treatment like this would be for somebody and talking with them really carefully about what that would involve and is it really right for them. And for folks who are older and may have other conditions as well, and really thinking about how something like this fits in, what could it possibly add to their life and their quality of life, and what could it possibly take away. And since we're at the point where we're still learning so much about these treatments, I really think about how to advise people at this stage. I feel very fortunate that as a generalist, I can partner with specialists who are giving these treatments for their perspective on that too. But I think for some folks, it's a big undertaking and a big deal to consider a treatment like this.
Thank you. Jane, if you would like to add anything from the caregiver perspective.
Yes, for sure. I do think it's important to have a generalist. My mom is the family member who has Alzheimer's. And because of where we live, we are lucky enough to be close to St. Louis. So we have access and know about um, research on more things that a lot of people wouldn't. So my mom liked to avoid going to her regular doctor because she thought she was in great health all the time, which she is with this exception. But we had noticed the cognitive issues. We got her initially to her primary doctor and they were open. So it did make a big difference. The ease of access and our goal is her quality of life, which is her goal as well. But having her primary doctor know or be aware, be able to have access to information about it made a big difference for us as far as getting care and getting access to more advanced care, specialized care.
Thank you. Dr. Raji?
From the imaging standpoint, I can say that a lot of neuroradiologists are still learning about how to understand and report ARIA or amyloid related imaging abnormalities. Thanks to the efforts of the American Society of Neuroradiology, we published several guidelines that provide advice on protocol, interpretation, and reporting. of the common sequences used for identifying RAE and RAH. We also have been looking at newer techniques, which could potentially give us earlier indicators of treatment response. And these emerging techniques will continue to more fully integrate our understanding of how these anti amyloid drugs work and how they can provide better treatment response information and related treatment pathways.
Thanks. That's really very pertinent because, of course, radiological monitoring is a key feature in treatment with these antibodies. Let's turn now to the importance of collaboration and shared decision making between patients and caregivers and other friends and family and their providers in making decisions about these treatments. I think it goes without saying that there's a number of people involved in caring for people with Alzheimer's disease or memory complaints or memory concerns that are proven to be due to Alzheimer's disease.
I would just like to comment that my mom and dad still live independently. My dad has some medical issues, but nothing that's cognitive. They live very close to us. My sister or myself are the primary third wheel at these appointments. And it is important, I think, to involve additional family members, even though sometimes I know that's a hurdle, even if it's to allow them to be on the phone during a visit or something like that, because my dad will be like, no, I think it's fine. Those sorts of situations. And where we may go a day or 24 or 48 hours and not see them right away, we may notice things that are different. So I think to add an extra family member, if it's still spouses or partners living together, to have that extra support. I think if that person can be looped in, it's vital and really makes a difference.
Yes, you bring up the question how big a support network any given patient has. Some of them may not have any caregivers and may live alone and may take a taxi to their appointments. One question that we touched upon was who does what? Obviously, patients and their caregivers have an important part of it because the patients undergoing the infusion and undergoing the MRIs. Of course, it's the primary care practitioners and geriatricians who are often their first interface with the medical system with regard to their memory change. Neurologists are typically the prescribing doctors for these therapies at this point in time. And of course, as we said, the radiologists have a key role in helping guide the therapy by accurately assessing any potential side effects and alerting the team to those.
I think that we as family have to come together and try and do our part at home. And I think that that's more important than everyone realizes, to make sure to relay the information and do our part on this side of the care, not just the doctor's appointments, but doing everything we can is just important for continued care. Also maintaining good information highway back to the doctors.
I really see the role as the generalist and the PCP, as we always do, which is really feel ownership over the whole person care of that individual. And that often includes whatever support family caregivers they have. We're getting better at this too with new structural opportunities to include caregivers and support systems, meaning we can now bill for assessing and educating caregivers. So, really taking care of that patient and the entire support system that they have. Of course, we're all in this space where we feel this remarkable moment of hope around these new treatments and hope that this is truly meaningful disease modifying care for Alzheimer's disease, which we have not had. When somebody has this diagnosis, it's just as important to be incredibly active about all the other aspects of care for dementia, Alzheimer's disease. That's going to include a brain health plan, supporting them for advanced care planning, ensuring that the rest of the care plan is concordant with goals, especially if we have this major treatment underway, and ensuring that they have time and opportunity to get information they need about the treatment and about the progression. And so that's really where I know I find a lot of joy in practice and supporting people living with Alzheimer's and their families.
Well, thank you. I think we all recognize how important the primary care practitioner is in many of the ways that you mentioned. Patients tend to have a fairly close relationship with their neurologist for the disease of their brain. But on the other hand, it's really key the partnership between the primary care doctors and practitioners and the neurospecialists. Dr. Raji?
Oh, to contribute the radiology perspective, we've been well integrated with our neurologists and primary care providers here at Washington University in St. Louis. And we've had quite extensive experience looking at individuals and helping them and treating them with these anti-amyloid therapies. And what we've learned from the acute care perspective is that if we have patients that are presenting in the emergency setting with suspected stroke or encephalopathy, particularly if they are older individuals, we do keep ARIA on the differential, especially if we're trying to establish a history of active current therapy with these anti amyloid approaches. And fortunately, because we have such extensive medical information, we are able to have that information at that time. Additionally, in the outpatient setting, when we do detect ARIA, even if it is not necessarily noted with any sort of symptoms, we do take care to inform our neurologists because we're exquisitely sensitive to making sure that we track this information and can take any sort of follow up assessments of patients through our neurology colleagues or primary care colleagues to make sure that they are in fact asymptomatic or in fact not feeling or exhibiting any subtle symptoms. And of course, in that process, having information from caregivers and family becomes vitally important. So we take a very team based approach to our care, and that seems to be a very successful model for us thus far.
Terrific. Thanks. I do think that it's really key that the neuroradiologist, as you point out, does take an active role in informing the neurologist or treating physician or practitioner about any potential side effects or any changes in the brain. Let's go a little bit further. I think Dr. Chodos touched on this earlier, and so did Jane Reams. As we all recognize, we're doing this for the patients to slow their disease and give them a higher quality of life. Of course, that sometimes means different things to different people. So we do want to make sure we understand in each individual case, but also more broadly, what's important to patients, their caregivers. And perhaps I would ask Jane to again make some other comments about what's important.
For the treatment, I would just say it is important to quality of life. That is my mom's main focus, and that's what our focus is for her because those are her wishes. But definitely watching the risk versus benefits. She did experience ARIA and had some microbleeds. They resolved and she was able to continue treatment after a break. And that's what she wished to do as well. So I think making sure that we have those discussions with her and get as much information as we can get. And it helped my whole family learn a little bit more of what to look for, having that experience, because there was several instances that she had had some symptoms of the microbleeds that were written off as, oh, it's just part of her Alzheimer's. She was having a bad day, different things like that. So there was a learning curve there with my family that were with her for the day or two that it first happened. But I think just understanding and having that communication is great. But overall, maintaining the quality of life that she wants is our goal and what we try to support for her.
I think, as Jane illustrated really well, it's going to be an individual conversation and really working with the person living with Alzheimer's around how should we involve your caregivers. If you do have that support, we really should, helping them understand the purpose of doing the decision making together, just so that we can represent that patient well when things are more critical or we're at a decision point. Realizing that these are going to be so individualized and changing, and that we're going to need to revisit. So, as the treatment goes on, if it turns out the side effects aren't tolerable or aren't acceptable anymore, that's okay. But we still have that dialogue ongoing. And usually with older people with multiple conditions, this being one of them, there's somewhat of a prioritization going on around what's most bothersome, what's most on their list of things that they're worried about, the things that they're really hoping to prioritize. I'm really interested in understanding what they're hoping for and what they're most concerned about so that we can really stay focused on those and continue to ensure that they have the information they need to make up to date and new decisions around it.
Perhaps we can go on to talking about these risks and benefits. And I think both of you just alluded to that. Of course, everyone is completely different. It is an individual decision. There's always risks and benefits of any therapy. And of course, it's very personalized how any given individual and their family perceives this. Something that one really has to keep in mind, that one has to not only look at each patient's perspective, but the family, and hopefully the practitioner helps be a guide rather than a dictator. I think that's really key. And sometimes, even though a therapy has been around for a few years, practitioners may be completely unacquainted with it.
Yeah, I would definitely say that most of our patients are not yet acquainted with it. Maybe they've read a news article or something. As is the case with all of these complex treatments, just being sure to offer information about the risks and benefits at a level that's appropriate. The simpler, the better is always helpful for folks, especially if they're living with some amount of Alzheimer's disease, and offering whatever additional resources you can to help people educate themselves. And then I think the really, really big benefit to keep in mind is to not oversell the impact. It clearly clears a lot of amyloid, but this is disease modifying. It's not curative. I think that's the other thing to just be clear about with people. And we don't know what it will look like to be on these long term. And again, I really serve as a role of early informer and then refer, so that somebody who is providing the treatment, they're going to have this conversation all over again, thankfully, and as well they should.
Yes, it's clearly an ongoing process. And as you know, everything doesn't stop when they leave the neurologist's office. They continue to see their primary care doctor and will have ongoing discussions. And of course, they continue to be focused on their MRI scans and what the radiologist is discussing about their findings. One issue that comes up radiologically is that there's a lot of different modes and forms of reporting. And I know you mentioned earlier the American Society for Neuroradiology, Dr. Raji, and how they're trying to provide some potential structure to some of the ways of reporting the results of brain scans.
One of the efforts that the American Society of Neuroradiology has led is the importance of emphasizing in reporting for ARIA, for example, the need to very specifically count and report the number of microbleeds, foci of superficial siderosis, as well as any pre-existing small vessel disease. And the reason we do this is because it aligns with the requirements of the FDA label for these drugs that have specific criteria for determining ARIA E, ARIA H, as well as the microbleed burden that at baseline can be very high risk.
That's really helpful. So I think it's worthwhile discussing together, each with our varied perspectives, the practicalities of treatment. After the decision's made to initiate treatment by the practitioner and the patient and their family as a shared decision, it's a matter of scheduling infusions and monitoring the infusions at the infusion centers and scheduling the MRI follow-ups. Then there's the ongoing communication. And then finally, there's the questions about long-term therapy. And I think Dr. Chodas alluded to that earlier. We don't really know whether there's increasing benefit over the years or stagnant or no benefit. So there are considerations for when to monitor amyloid load in the brains by PET and whether one should consider stopping treatment. Perhaps I would let Jane mention from the patient family perspective the practicalities around initiating treatment.
Yes, thank you. My mom was actually somewhat resistant because she knew what it might mean, but getting the diagnosis and then being able to now get the infusions, it went quickly for us, I think, because of our location and a good primary doctor. We're here now, but it is an ongoing talk about where we at and the risks versus benefits.
Yeah, I think sometimes people don't realize what a benefit is to get amyloid confirmation or non confirmation, because, as you say, the not knowing is often the worst part. And unlike 5 years ago, we have proven treatments. Why don't we talk a little bit about managing ARIA risk? I don't know if Dr. Raji wants to step in here.
Yes, I'd be happy to talk about managing ARIA risk. It's important to identify at risk individuals for ARIA before treatment and to adhere to an MRI monitoring schedule to allow for dose titration, discontinuation, or interruption of treatment. The important thing is to understand the underlying genetic profile in terms of their ApoE4 status. If individuals are homozygous, they'll have two copies of the ApoE4 allele. And that's important because there's a higher risk of ARIA-H in individuals with this particular genotype for ApoE4. And so understanding that baseline risk is going to be important because then there would be a close need to monitor with these scans the higher probability of ARIA-H in particular. The other nuance to understand about ARIA, especially with respect to the trial data, is that while ARIA-H is something that we scrutinize very minutely in clinical practice, it's important to note ARIA-E because ARIA-E tends to have a higher correlation to adverse clinical outcomes. And so having close assessment of the MR imaging will be very important. Making sure that we catch those cases early and initiate treatment or appropriate management is quite important. And the other thing that's important to know is that in our experience, when individuals do have ARIA, we'll typically image them every month for several months to ensure stability or resolution of the findings. And why is that important? Because ARIA-E typically resolves in virtually every case that we know of. ARIA-H, on the other hand, is persistent, but since RAE is the more clinically problematic of the two based on the trial data, we do want to, in particular, make sure that that particular set of findings is resolving over time. And of course, the clinical treatment really depends on how closely the neuroradiologist can communicate the results. And then the neurologist or primary care doctor, either in conjunction with the neurologist or as part of that team, can come to a conclusion about the best approach to managing a particular patient.
Yeah, I think you touched on quite a few very important factors. We did talk about treatment a little bit. Typically, most practitioners with expertise in these therapies do not use any corticosteroids or symptomatic therapies for ARIA-E unless it's symptomatic. But of course, there's a variety of opinions, and some people might treat asymptomatic ARIA-E when it was massive. Uh,
I'll just add briefly that in understanding RAE, the measurements can vary depending on thresholds of 5 centimeters or less, or 10 centimeters or more for delineating moderate to severe RAE. But it's also possible to have multiple areas of RAE that might be less than 5 centimeters or in between. And so delineating these in the report will be very important for the radiologist to convey to the clinician because as noted, these can have higher rates of clinical consequences than ARIA-H alone. And then, of course, when we report microbleeds, we also make sure to note the location as well, because one of the overlapping pathologies that can also increase the risk for an adverse outcome would be underlying cerebral amyloid angiopathy, which is why doing a baseline scan prior to the initiation of treatment does become quite important.
Yep. When the radiologist is communicating the results, they're not only communicating them to the neurologist, but also to the patient and their family who may be actively on the portal. Well, before we conclude today, please take a moment to think about how you all might change care based on what you heard today. And if you could please write your comments in the space provided, we'd be most grateful. As our time for this effort draws to a close, I know we've spent a lot of time on safety, and that's important. We don't want to lose sight of the fact that, of course, the efficacy is what drives the therapy, but we have to balance safety and efficacy. I think at this point, we can let each of you offer one or two quick take-home points. Maybe I'll start with Dr. Chodos as the primary entry point for our patients.
Sure. I think for me, the take home is if someone is considering this therapy or on this therapy, that we're still doing everything else, being very active around care for the condition itself and aspects of brain health that aren't the medication, as well as helping to support their caregivers and them, regardless, but especially if they don't have a caregiver. And then as this gets more and more common that folks are on this, that generalists and ER physicians and everybody know the signs so that it isn't missed when someone is having a complication, because I don't think it's quite in our pattern recognition yet and awareness on the differential if folks are on this.
And I'm also very happy to see that the role of neuroradiology is changing from the traditional rule out so called organic causes of dementia to being a critical partner in helping to implement these treatment changes. And as the quality and precision of these therapies continues to evolve in the future, as with other fields of neurological medicine, such as multiple sclerosis, we'll see that the treatments should become better and better over time, producing a wider range of good clinical benefits and lower side effects. And so being part of that journey with the clinicians and the patient from a neuroradiology standpoint is quite exciting and meaningful.
I think my biggest thing is that to be the best steward for my mom's wishes while balancing her care overall and her quality of life. We can collaborate to be the right supportive family member when it comes to her appointments and trying to maintain as many things as we can to be as successful as we can. And just know it's very appreciative of all your roles in her care. These sorts of things, I think, in the long run will improve the patient care. So, thank you to you all for all you do.
I know it's been, of course, a dramatic thing for you and your family. I should say it's been a dramatic thing for all of us practitioners to finally, after many decades of being more aware of Alzheimer's disease, to have these effective treatments and to learn how to use them and how to manage them appropriately. So I'd like to, at this point, thank you all for this really excellent discussion. And I think we can continue on for the evaluation period for the participants. So thank you all for your participation again, both the discussants here with me and all the participants listening and viewing. Thank you.